So thank you for joining this evening for our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give a brief overview of our free programs for those attending for the first time. So we'll go over who we are, what is our program, introduce our speaker, and then we'll do a Q&A. Again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter Deanna was diagnosed with hypermobile EDS in 2008, the same year my wife Carol passed away from breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our programs at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've been a sponsor for many conferences and EDS events. We've started or supported over 100 EDS support groups to date. Each group is given their own free website with a link to the directory and map. In 2019, we presented a program to help EDSers organize and manage their support groups in Facebook. Mandy Harvey was a guest speaker for that program that was web streamed and recorded and posted on our EDS.com site. We received feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We have over 100 webinars, 50 different topics, 60 different presenters that you can search by presenter's name, topic, and location. Our healthcare providers educational program was introduced in September 2017. It provides free online continuing education credits that healthcare providers need to renew their licenses. It is receiving an overwhelming response from the medical community worldwide. Anyone can attend these programs. Since nurses spend more time with patients than doctors, we introduced the first online EDS nursing education program in 2020. We have 3 programs set up on the site. We have 3 in the planning phase. Unfortunately, the COVID slowed us up with the last 3. Many of our speakers in our programs have contributed to this newly released book, Disjointed. We have a book review on our site. Please sign up for our EDS Awareness Monthly newsletter. We introduced this in May 2021 for EDS Awareness Month. And here's a list of the links to the resources we discussed. This will be part of the slide pack that will be posted on our site with the recording. So let's get started. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment. For those attending live, there will be opportunity for Q&A after the presentation. Add your questions at any time by clicking the Q&A icon on your panel. After typing your question, click the button to submit. Please provide a question that is of general nature. The doctor is not in a position to do diagnosis on your personal condition. So again, we're very pleased to have Dr. Eli Penn with us this evening. He's going to talk about hypermobile Ehlers-Danlos syndrome and the gastrointestinal tract. Dr. Eli Penn is an interventional gastroenterologist at Atrium-Navicent Health System in Macon, Georgia, and associate professor of medicine at Mercer University School of Medicine. He spent the first 10 years of his career pursuing a mastery of new technology in his field. But having been in solo practice, he recalls many patients whose symptoms he could not explain. He realized that his clinic was full of hypermobile EDS patients, up to 20% of referrals, and soon suspected that hypermobile EDS was in fact much more common than he had been taught, and the patients were being misdiagnosed. Dr. Penn now reads constantly about the condition and has learned a great deal about hypermobile EDS from his patients. He has become a passionate advocate and spends much of his time trying to enlighten other physicians and healthcare providers while caring for his hospitalized hypermobile EDS patients in his clinic and during student lectures. He quickly found that the world of disenfranchised hypermobile EDS patients gathered in cyberspace, and his career took on a new purpose. Dr. Penn joins us today to discuss his experience with hypermobile EDS in the GI clinic and what he has learned about the basis for some of the seemingly disparate symptoms. He will also talk about treatments that have helped his patients and why he believes that education of all physicians, students, mid-level providers is paramount to bringing about a more rapid paradigm shift that we have seen than any other revelations in recent medical history. So we're very pleased to have Dr. Eli Penn with us, and I'm going to turn the microphone and he can share his slides as well.
Okay, thank you so much for that introduction. Let's see here. I was saying that there's not been anything quite so impactful in my career as this realization, and I feel like there was a lot of people that have, I've neglected, I've missed. And I've always felt that way about less common diagnoses that I really didn't appreciate, and I've tried to go back and call people and determine sort of if they had the problem that I learned about, because we do learn after training. But this one's got me hooked, and I think everybody listening probably understands that in a very visceral way. So I'm hoping to communicate a few points tonight. As John said, I learned probably half of what I learn about this from my patients, and unlike any other disorder I've ever encountered, the patients are so well educated, much more than most of their physicians, and that's a little intimidating. It's one of the obstacles we'll talk about, because I want to let you know how I think maybe we can improve engagement of physicians with patients with this diagnosis, because there's a lot to learn. We certainly don't have all the answers, but the first thing is recognition, right? So I want to communicate sort of what in the GI clinic, what the typical presentations are, because we think that maybe most people come to GI first. It's in one particular database, 82 or 86% of patients had GI symptoms. So it's extremely common, and it's an opportunity not just to address those symptoms and correctly make the diagnosis, but to help triage patients, guide, I should say, patients to where they need to be. particularly if they've never heard of this, like most of us. So how we present, and I say we because I have this. I'm embarrassed that it took me 45 years of my life to make that connection. I'll talk a little bit about that, but that's how I'll be referring to us in the plural sense. I want to talk about the mechanisms for our symptoms, or what we think makes us feel the way we do, and some of the historical ideas and how we can sort of counter those. Talk about physician engagement so that people can get the care they deserve. And then I want to make you aware of some of the future potential therapies that are coming down the pipe that I think, based on the mechanisms we'll talk about, could be extremely helpful. And I hope to sort of pepper the talk with some case examples of patients I take care of this very day. Oh, let's see here. Okay. So my background, obviously I went to medical school, internal medicine training, a gastroenterology fellowship, and then I got into therapeutic endoscopy. Let's see here. Oh, I may see what's going on. And that path actually led me to study this disease. So I was not too far off base, even though it was so different. These are some of my mentors along the way, and my sort of focus was interventional, sort of the surgeons on the left in Charleston, very good surgeons who I continue to send people to for the invisible diseases when patients are doubted, and particularly the pancreas. And then on the right are my internal medicine gurus who showed me just how far the mind can go. I never got there, but that's what I look up to. And then sort of married between them is a hybrid of internal medicine and surgery, which is the specialty of GI, or so I thought. Resume. There we go. So one of the things I've gotten into was endoscopic ultrasound, and we'll talk about how that might help people like us. But one of the things it does is it allows me to see things that are smaller than CAT scans can visualize. So this, for example, is a very small focus of a tumor that is metastasized from the pancreas in a patient who seemed to have early pancreatic cancer. Unfortunately, this was a bad sign, but very powerful modality. And so I've enjoyed this. It allowed me to find these patients. This is a picture of a pancreas that's very scarred. And there's some circled and squared features that tell me that it's chronic pancreatitis. So there are people like us who are searching for someone who will believe them and have terrible pain, but normal labs and normal CAT scans for years. And they tend to start early in life. So it's actually one of the things that I consider in the list when one of us shows up with gastroparesis, which we'll talk about, because there's a list of things we need to consider. So EUS allows me to sort those folks out. It also allows me to intervene on patients with chronic pancreatitis and pain by doing a celiac plexus injection. And I bet some of you might be thinking of other applications for this, but it's a very powerful tool to relieve severe abdominal pain, either from the pancreas or a few other sources, such as mouths. And I know that's a hot topic. Technically, it's in our territory of being in the GI tract, and it's certainly within the territory of endoscopic ultrasound because it is right in front of the scope. So when I find a young patient who has severe pain after they eat, I think about three things that wouldn't show up on a regular workup, like a scan and labs. And one is mouths. It's relatively uncommon compared to the others. Certainly hereditary pancreatitis is not common, but we see it. And then probably the most common thing is gastroparesis, or poor stomach emptying. And each of those can cause pretty severe, very similar symptoms. And so EUS can help me sort that out. Now, I threw this top right picture in because I think that our connective tissue disorder predisposes us to phenomena like SMA syndrome, MALS, and I'm thinking of the last thing. Common iliac compression syndrome. I think that our vessels are a little different, even if it's not type 4 EDS, and they're compressible, and they're, we're liable to get things tangled up, whether it's small bowel obstruction or one of these compression syndromes. So the most common presentation by far, and I mean, I see 2 or 3 patients every day I'm in clinic out of 15, is sort of nonspecific pain below the center of the rib cage, above the belly button, usually made worse by meals, bloating, which is a ubiquitous symptom, and distension. Some people feel like they look pregnant after they eat. Their belly literally grows. And they'll complain about that primarily, or nausea, and then occasionally vomiting. Vomiting is supposed to be one of the 4 cardinal symptoms of stomach emptying delay, but it's actually not everyone. And then feeling full quickly when we eat. So sometimes we get full very, very fast. Other times not so much. But most of the time it's different than our peers. And then irregular bowel habits. So all these things are most common in women. Just after puberty, these things begin to start, and they often come into GI first. Most patients have been to me before they've evaluated any of our other typical symptoms. And unfortunately, that description is exactly what has been defined as IBS for 50 years. And IBS has permeated our media, pharmaceutical companies, and it's never really been defined except by symptoms, which is very similar to fibromyalgia and interstitial cystitis. What else? So each specialty has a pet name for us because they don't know what's really wrong, but they think it's benign, and they kind of pat us on the back and send us on our way. And that's what I hope to put an end to. Very recent literature, which I'll show you at the end, has finally linked immune alterations in the wall of the gut with IBS. So they took patients who met the criteria for IBS, and on biopsies and special immunostains could demonstrate that in particular, the mast cell activity is what may drive the symptoms in quote unquote IBS. But my theory is that IBS is really us. So it's BS. I tell my patients it's a list of symptoms, and there are symptoms. And the problem, why we haven't been recognized, is the narrow focus of modern specialists. Less common presentations, but we certainly see them, are severe epigastric pain, nausea, vomiting, and severe weight loss. So I have a patient in the hospital tonight who is literally wasting away from a flare of dysmotility throughout the GI tract related to her mast cell disease. And so when I have someone with such severe symptoms and weight loss, endoscopic ultrasound is a great way to rule out the list of things that I've already talked about a little bit in one sitting. And then less common, but certainly not uncommon, we will show up with sort of a different pattern of altered bowel habits, and predominantly constipation type symptoms where we just feel really distended, but it's below the belly button. So it's a colon for the most part. And then there'll be, our connective tissue gets a little flimsy, just like everywhere else. And there'll be problems in the pelvic outlet where the bladder will bow into the space of the rectum or vice versa, or there'll be some prolapse. And so things just don't work right. And when they don't, we get obstructed, and no matter how hard we try, things get worse. And then you'll have some overflow diarrhea and assume that's the main problem. So that's one of the things that when I first started practicing stumped me. I figured everything was just constipation, but it's not quite that simple. And so we'll talk a bit about how to tease that out. So here's a typical workup, and I bet a lot of you have been through it, can relate to this. Endoscopy and colonoscopy, pretty standard. So you have stomach pain, they're going to check for H. pylori, check for peptic ulcers, right? Let's see, and that is unfortunately still our standard. You got to do the colonoscopy in a young person to rule out Crohn's disease. I think that is probably a little overutilized, but it's what's done when somebody shows up with those symptoms. And what I think is happening is that since we are so common, particularly in my office, we need to shift what's high probability away from the lower probability of Crohn's disease, for example. So our problems are much more common, and we've just not been labeling them properly. The other thing we do, so if somebody comes back after their $10,000 of procedures and they still have pain, we'll check their gallbladder first with an ultrasound to look for stones or thickening. And then we may, if we're good, consider motility. People don't like motility. It's hard to understand. We weren't taught a heck of a lot about it. It was still sort of a mystery area, but we've come a long way in the 10 years since I've been out. So we'll do a gastric emptying study, which is pretty poor. So it's not very sensitive for gastroparesis of the variety that we have, where we may not be vomiting, but we do have all the other symptoms. And when somebody does an endoscopy, if they're careful, they'll see that our stomachs don't move a lot, and there's a pool of fluid on the bottom of the stomach. Some telltale signs that validate our symptoms. But gastric emptying studies miss much more than implied in the literature. We know that because we do a smart pill transit study. Very, very often we'll show 5, 8, 9 hour delays, and people have had 2 or 3 negative gastric emptying studies. So I used to fight with radiology to get them to do the 4-hour gastric emptying study, which is a little bit better than the standard 2-hour. And I used their own literature to try to get them to do that. But even then we miss a lot of gastroparesis. So I've begun in my practice, it's not the guidelines, but I personally just do an endoscopy and pay attention. And just like paying attention to someone in your office and their history can yield huge results, so can a careful endoscopy. Unfortunately, I hate to blow the whistle, but a lot of endoscopies in the United States are 1 or 2 minutes long. And there's a lot of information to be gleaned from a careful endoscopy. Certainly not all of them, and you can tell by the doctor you have, but it's one of those things that people speed through because they underestimate the information that we can get. You take a biopsy for H. pylori, you're done. There's nothing else to know, and that's just not the way it is. So occasionally you'll get someone who will go the extra mile, but that's where most people end up. So most of us end up having an endoscopy, colonoscopy, gallbladder workup, including a hEDS scan. And then we get sent away with Bentyl, antispasmodic, and fiber for our IBS, and are told to follow up with our primary doc. And it's just a 3-ring circus. I mean, it just goes on and on. It's 30% of the business in GI clinic. And it just, unfortunately, is not very fruitful in my opinion. So here's what a normal workup looks like. I'm trying to draw it out in an algorithm. And I should mention that we very easily can get caught up in the hEDS scan realm where we look at the gallbladder emptying. Well, I'm sure that most of you probably realize that the gallbladder, being a smooth muscle, innervated by the same autonomic nerves as our stomachs and our colons and our peripheral arteries, are not functioning well if we're having autonomic flares, right? So if we start feeling bad, our hEDS scan may be abnormal, which hurts, but it's never killed anybody like gastroparesis. So I'm not saying that people don't need their gallbladder out, not at all. But this can be a detour where you get sent to a surgeon. The surgeon says, yep, abnormal hEDS scan, takes your gallbladder out. And guess what? You still feel bad. So you go back to your gastroenterologist and you get put back into the last part of the circuit. where you get a gastric emptying study, and sure enough, it's slow, or maybe it's normal, falsely normal, and then guess what? You get pentyl and fiber and sent back to your primary. So I really, I know I sound a little hostile about this, but I participated in it, and I think that I guess I'm trying to make up for that, because I hate that I missed so many people who needed me. So the dysfunctional diseases, because we joke about functional disease in GI, and it's not humorous, but functional doesn't mean dysfunctional like poor squeeze. It actually means that we think there's something wrong with your brain, that psychiatrically your symptoms are coming from your head. And so that's a really distasteful use of the term. It should mean that there's a dysfunction of an organ system or a nerve. And I think that's what it was meant to mean, but it's morphed into to mean basically psychiatric abdominal pain. So in the cycle of dysfunctional diseases, in GI, we have IBS and functional dyspepsia, which by the textbook is anybody with a negative gastric emptying scan, but seems like they have gastroparesis. And there's nothing you really do about that. And so sometimes we get sent to general surgery again for a hEDS scan. And it may or may not be positive. A lot of times you'll get sent to a gynecologist for pelvic pain, and even end up with surgery, or not that endometriosis isn't a problem, but that's a frequent thing to look for in people who show up with our symptoms. And then urology has their name for us. So the smooth muscle of the bladder clearly does not function well either. So we have to urinate a lot. Sometimes on the hour, sometimes 5 times a night. And boy, is it annoying. But the urologists don't really know what to do with this. The good ones will teach us sort of exercises and to retrain the bladder. But some will just say, well, just go to sleep with a Foley in catheter because there's nothing you can do. And so that's another pet name for us, the interstitial cystitis. And then orthopedics and rheumatology, not that they're not excellent at what they do, but, and yes, I saw a comment there, mast cells are in the bladder too. Absolutely. I can't wait to talk about that. But the orthos and rheum will, unfortunately, they'll see us, and we're so young, the women who show up with this at 17 years old, they don't consider osteoarthritis, right? Or, damaged bone structure. And so they'll either send you to rheumatology or back to your primary care, and with a presumptive diagnosis of fibromyalgia. So most hEDS patients will meet the criteria for fibromyalgia. So a lot of patients come to me already with that diagnosis. If they haven't yet, I tell them to try to avoid it, because we get arthritis in our late teens and early 20s, and we start hurting. And that was one of my symptoms that I'd overlooked. And then the poor primary care docs get us back. No, not just fibro. So it's painful, all right. But the primary care docs have all these things that the specialists don't know how to define or treat, and then they don't know what to do. And then you have this long list of problems that are all sort of non-specific with no treatment plan. Very, very frustrating. So I probably, the online presence of hEDS patients is fantastic, and it's an army. It's, so many people who are frustrated with these diagnoses. But what I've learned is if I take my time, not much time either, once I recognized that all these patients had some things in common, and read more about hEDS, I knew what to ask. And so I go down the list. Sometimes I'll do it when I walk in the room. I've started to recognize sort of other zebras just by the face. We just kind of look the same. And so almost everybody has migraines, not everybody, but almost everybody. Easy bruising. I try to put them in order of my perception of the frequency. So everybody has easy bruising. Constipation. Now that's tricky because not everybody realizes when they're constipated. We all think we're normal, just like I did for 45 years. I thought everybody had to take Motrin 4 times a day and had a little kidney trouble for their joint pain. But constipation is one of those things. So you have to educate people on what it's sort of supposed to be like. The joint pain is also nearly ubiquitous, maybe not quite everybody like the migraines. Here and there, people will say, I really just don't feel bad. And it surprises me, but I was speaking to a waitress when I was at lunch with my children, and she looked like one of us, so I had to ask her a few questions, and she said that her back pain was because she is up on her feet all day. And, you know, that's the kind of thing we tell ourselves, that I only eat once a day because I'm busy. It's just amazing. It's sort of how we get to that state. So these, if you can elicit if I can elicit these yes or no answers to these symptoms in my patients, which is why surveys are probably not good enough in the research world. But if we really talk about it, everybody has this. So the MCAS symptoms can be the sneakiest. So my MCAS manifestation is mainly migraines. Only Aleve makes me have hives, but I presume that many exposures are going on that are driving this process in all of us, and it's very hard to identify the antigens. And then palpitations. So for me, palpitations led to an echocardiogram, which led to the scare of my life, aortic aneurysm, which is actually a rare, not rare, but a less common feature of hEDS. We can get that. But it's important to know that it's not as dangerous. So they wanted to cut me wide open, and that was not the right thing to do. We don't rupture like some of the other connective tissue disease folks. So I wish I would have known at that time. I would have been a little more confident in the decision to wait and watch, and it was the right decision. And some of us will say they've passed out, not from drinking, and that's a pretty sure sign of autonomic dysfunction if you've ever passed out. And then frequent dizziness. So it's taken me a few years to realize that I've actually had that a few times. Again, you just assume everybody goes through that. And so you're not really a lot of help to the physicians who don't know about hEDS if you haven't already sort of examined yourself for these. So it's a good thing that we all read. On an exam, it's fairly easy, quick. Hypermobility obviously is not something a GI doc usually does, but since I've started doing that, it gives me clues to the symptoms you have, and I really don't have to do all those expensive tests to know what the problem is. Arachnodactyly is an ugly word. We have sort of long, I tell female patients, long, pretty fingers, because it really, you know, our skin is attractive. It's very soft. A lot of times people don't even have to wear makeup. Yeah, piano player fingers, exactly. That's where some of the terms come from. You know, we've been around for eons, and we were double jointed. We had growing pains. We had piano player fingers. I've heard that too. And so arachnodactyly is a derogatory term I wish we could change. Stretch marks before pregnancy or weight gain, so as a teenager, are a pretty sure sign of abnormal skin, and a lot of us have that. And then mitral valve prolapse is very common, but most people don't know they have it. And what GI does a good cardiac exam anymore? So taking, I would say 15 extra minutes on this part pays off in spades for me and my patients. And I'm trying to argue to other GI docs in big places that this is not something to be afraid of. It is not harder to take care of than IBS. Not only is it more important that we get it right, but it'll make it much easier down the road if we take our time on the first visit, make the diagnosis, and get patients what they need. So everybody knows about the worksheet. So I certainly use that and document it in every note, because there's bound to be skepticism from primary care docs and other specialists who haven't heard of this, like me only a few years ago. And we've all heard of it. We just had no idea it wasn't the rare disease we were told. So in my clinic, yep, John's right. Out of all patients who come in the door over 6 months, from July, starting in July, 10.6% met the Villefranche criteria and had typical symptoms. That's pretty amazing. And then if you look at the people who were sent for abdominal pain, it was 26.2%. And so that's really, I mean, we're approaching a third of what GI doctors do for a living has to do with EDS. I mean, I can't imagine anything bigger than this in modern medical history to when this sort of comes to fruition and everybody is forced to recognize it, which is about to happen because we finally have some genetic information about us. And that will force the issue. We'll have real prevalence data from a gene perspective, and there'll be no way to hide our heads in the sand anymore. We will be heard. And that's pretty exciting. It also implies a treatment would be possible because of the mechanism, but I can't talk much about that. I will say that I do have male patients. Yeah, exactly, Norse Lab. I have male patients, not nearly as commonly, but I have several, and they really suffer at a young age too. I have 2 female patients who I've known for a long time, and I only recently realized that they met criteria, and they were masked in a way, I believe, by being on testosterone replacement. So I do sort of out of curiosity check testosterone levels on new patients. And I can say I have a very high percentage of young females with undetectable testosterone levels. Interestingly, some have high levels and PCOS, but I would say the majority have undetectable or very, very low levels. Well, we were also taught in medical school that testosterone is to make men men and women women, and that just doesn't really, it's not the whole truth. So testosterone major role is to protect the nervous system and to help it regenerate from injury. So that's interesting. So I've done a lot of reading about that and some of the different uses, but there have actually been some EDS patients who were started on hormone therapy to make a gender change, and their POTS would go away or nearly go away, and some of their other autonomic symptoms would go away. So there may be a role there, but it also is an important clue that this is a multi-system disorder. And the final thing I'm going to talk about, I'll try to speed up, is how we think about disease and how that may have to change after this. So bladder function and MCAS symptoms were also less in the testosterone, the 2 women taking testosterone. And I know the immunologist will use danazol, a weak androgen, for certain allergic diseases. So this is the pie graph of my clinic starting in July. And these were, people have started coming because they see me on the EDS website, but before that really started happening, this was sort of the raw percentage of all comers. And I just think that's amazing. And it's not inconsistent with what we were told in 2013 by Cleveland Clinic. It just fell on deaf ears. I don't know. I don't think people want to know this. So here's what we should do with hEDS patients when they come to a GI clinic. You saw what we do, and that is reality. This is what I do now. So I diagnosed them with hEDS by the Villefranche criteria, which are, I'll try to share that later. Dysautonomia, that's automatically dysautonomia if you have multiple smooth muscle organs with malfunction. POTS, bladder problems, gastroparesis, constipation, there you go. Migraines or autonomic dysfunction. And then I usually diagnose them with MCAS based on their atypical allergic reactions, either to tape, almost seems like 80% of us are intolerant to tape, and other inert substances, and multiple drug allergies, Benadryl in some people, the poor people, because doctors love when somebody says they're allergic to Benadryl or, God forbid, steroids. The girl in the hospital right now is allergic to corticosteroids. And so nobody believes that until she stops breathing. So some of those patients don't even go to the ER anymore. So what I do is I do this. Now for my part, I will do an echocardiogram if you haven't had one already to screen for dilated aortic root. If they have neck pain, I will get C-spine films, plain films, and a C-spine MRI to look for glenoaxial instability, Chiari. We can have tethered cord syndromes, all reasons to see a neurosurgeon. And Sunil Patel at MUSC is very much a proponent of taking better care of EDS folks. So that's a name to remember. The immunologist we have here where I am now is excellent. And there's one not too far away in Atlanta who also is as knowledgeable as we can be about MCAS. There's an exciting drug coming out that was supposed to be for EOE. It's going to maybe work wonders for MCAS patients. It's Ted Lee, yeah. And we were just on the phone the other night about this patient right now. But we're waiting for the drug, which is a biologic active against mast cells. And I'll send them to EP, cardiology for POTS if they're symptomatic. I always try sodium tablets first. Who wants to take drugs? They don't have to. I put everybody on low-dose naltrexone. People absolutely do fantastic on it. A few of us seem to feel funny and can't take it. I'm unfortunately one of those. I would love to have some relief, but it makes me mentally foggy. But most people just get such relief. Theodore Lee is his name, and Jeff Langford here south. Low-dose naltrexone, 2 milligrams. So naltrexone may help with MCAS and the pain. So by suppressing opiate receptors, blocking them, theoretically our body produces more endorphin, our natural painkiller. You don't get high from it, you don't get dependent on it, it's not dangerous. And it also seems to help with the immunologic derangements we have. Some of the other tests I'll order are smart pill if I want to track motility in various parts of the GI tract. Interestingly, I've noticed that our small bowel seems to be preserved, the motility through the small bowel. It's just the stomach and colon in almost all patients. Why the small bowel left alone? It's not because it doesn't have the mast cells, they're there. I think it's because evolutionarily it was so important. It's the only part of the GI tract we have to have that's somehow protected in a more robust way than our stomach and our colon, which are not essential like you would think. So motegrity I'm a fan of for gastroparesis and constipation. So it's kind of an agent that works on both. It stimulates both the stomach and colon. I will send people to Urogyne frequently for the pelvic floor problems, outflow obstruction, or constipation related to pelvic floor problems. But that's the extent. I do an endoscopy, a biopsy for mast cells, get the special stains to try to help the immunologist. And then occasionally, if people aren't doing well on the motegrity or the dietary restriction, then we'll consider GPOM. I do a lot of those. I try to turn it back over to the primary care doc to get them invested in the diagnosis and treatment and have them check thyroids, monitor hemoglobin iron studies, malabsorptive type problems and replacement, and anxiety. So we all get anxiety in one form or another, many ADHD starting at puberty. And that is not just females, that's males too. So that's kind of interesting. But the days of thinking that somehow psychiatric disease could not be explained by GI disease or peripheral nervous disease are gone. It's all related. And that makes more sense anyway. The conception of different systems was a human conception, and that's not how our bodies are made. So next goal here was to talk about some of the mechanisms and treatment options. So this was a very pivotal study that came out, I think it was this year, where the gurus of IBS, who have just spent years on top of the hill about IBS and what to do, were able to prove that that mast cells were more active in doing sort of dangerous things that damage the the autonomic nervous system in IBS patients. So they showed a relationship between this immunologic problem and IBS, which I find interesting because I really, I did not like what they were doing by categorizing everybody, but I guess that's scientific, particularly when they put this out there. So it really redeemed their work in my mind. They've linked things back to a testable, mechanism instead of this nebulous term, because things like IBS and categorical diseases without tests get us blown off. So we used to, and actually still do, cut the vagus nerve sometimes, vagotomy, and people have non-healing ulcers. That's a big no-no. I mean, we did that to stop acid production, but it also stops motility. So it'll make you pretty darn miserable. But that's not the mechanism of gastroparesis in us or even diabetics. This slide down here at the bottom shows you the nerve cells running through the muscle layer in the colon, surrounded by these bright red mast cells that are labeled by a tracer. And so it literally, the mast cells really secrete prostaglandins, cytokines, and toxins that damage the nerves over time. So it's no wonder they don't work. So most people with gastroparesis can get by on, changing their diet, avoiding roughage. I love this Kate Farms nutrition. They've got an app for your iPhone, and almost everybody can get by on Kate Farms. It's pea protein, no corn, no soy, and this one is 500 calories per 11 ounces. So if you can drink 3 of those a day, you're going to be okay. That's pretty easy, even if you feel bad. So that's keeps a lot of people out of surgery and J tubes if they're willing, and most of us become willing because it feels pretty bad to be nauseated. And then below that is the GPOM or POP procedure, where for about the past 10 years, we've been digging tunnels beneath the surface of the bottom of the stomach and tunneling down to the pyloric sphincter and cutting it. And if we cut it, it will not be able to contract. And if it doesn't contract, then the non-functional stomach can empty. So it doesn't fix gastroparesis, but it certainly will allow you to empty much more easily when your stomach is atonic. It doesn't work for the most severe cases, but those are only 20%. So for most people, this is a game changer. It can really improve quality of life. We have recently found data, or we have data saying that we need to test this first by doing a Botox injection to see if relaxing the muscle really helps. And your doctors, anybody out there is getting that done, it needs to be 200. That's something I recently learned. 100 is not adequate. It gives you a 48% response rate. 200 units of Botox, which is quite expensive, gives you like a 75% response rate. And so those 75% of people who respond, I take and offer pylorotomy. But if they don't respond, then there's no reason to do that. So if they don't respond, what do? Well, then we move down the line. So the prokinetics like Motegrity, I try never to use Reglan. Most people know about the rest of that. Jejunal feeds are standard of care. So we'll just put a tube in you and send you on your way. I think that's not the best option. So I think pylorotomy should come first. Gastric pacing is something I had a bad attitude about a year ago, and one of my young patients had a great response. So I'm excited to learn more. Anything that can sort of help hEDS patients who are stuck, because there's not many people who sort of want to get involved still. And then the ultimate treatments for gastroparesis, and I have 2 patients who've had this, is Roux-en-Y gastric bypass. So a weight loss surgery, but in gastroparesis, it actually serves to help you gain weight. And I'll explain that. If Botox is one way to assess whether GPOM will help somebody, but also we have these fancy manometer balloons we can put in the pylorus and measure distensibility. This is a surgical algorithm. There's not a lot of data for this. Most people try to steer clear of us, but this is something that we've done here at Navicent, Atrium-Navicent. So people who are really intolerant, can't eat and maintain their weight with prokinetic drugs, we'll offer pylorotomy if the Botox works. And if that doesn't work, if they still have gastroparesis, and it's pretty clear, then we start considering surgery. And I was sending people for a sleeve gastrectomy, but that actually doesn't work so well. My algorithm is more similar to this one, consider gastric stimulator after pylorotomy fails, if it fails. And it's not always a primary failure. It can be due to evolution of the disease, but stimulator makes some good sense. So that's sort of a new tool in my arsenal. And then ultimately, Roux-en-Y. So we'll make a small stomach that'll empty much more easily like this than this big flaccid wet paper sac, basically, that's not worth having. So stomach's not worth having if it's not moving. Same with the colon. So this is, let's see if this is meaningful because I'm going to try to speed up here. This is a young patient who had pylospastic variety of gastroparesis and severe neuropathic pain related to the pylorus. And we were able to really make her hurt much worse with the Botox injection, with air insufflation. I've really never seen anything quite that bad. So the mast cells that live around the nerves, the myenteric plexus of the enteric nervous system, one of the prostaglandins they secrete basically turns up the volume on nociceptors, the pain receptors, so that they're sending signals like mad, like you've been stabbed to your brain. And you obviously can't ignore those, but there's not because there's actually harm. What an awful problem to have. Looks like this is maybe, I'll skip the next one. So she had terrible pain. And interestingly, the pain was relieved by two things. One was, so what causes the pain like being stabbed? Good question. I think it's coming from the nerves themselves. So in this patient, a little insufflation of carbon dioxide gas into the stomach during endoscopy led to the same pain that a normal person has with perforation. So severe. And it's a false signal, best we can tell. Now to prove that, we injected this pyloric sphincter with a numbing medicine like lidocaine, and her pain completely went away. And so pretty amazing. The other thing that surprised me is that when we cut the sphincter and released the tension on the pylorus, the pain went away. But basically, her disease progressed and had a different phenotype of gastroparesis. So even though she did great at first, she ended up needing a pacemaker. But she actually is doing much better than she was in the beginning, when everybody thought she had an eating disorder. And that's another thing that happens to us a lot. The problem is some of us do, because it feels good not to be nauseated anymore. So I can see how people would vomit, particularly a teenager who was sick of throwing up or sick of being nauseated. I can see how that would easily become a cycle. So some of us actually develop eating disorders, but many of us are sort of labeled with that, even though we just can't eat. This is what it looks like when I do an endoscopy in full stomach. And this video, you've got to see, I really hope this will play. Yep. This is the GPOM procedure. So this is where we inject a little gel underneath the surface of the mucosa to expand the submucosa, where we're going to submarine underneath the mucosa and but inside of the muscle layer. So by submarining between those layers when it's expanded, we can safely drive down to the sphincter and cut it. And we'll actually, for a brief second, we can see the liver. We can see the peritoneum as we split the muscle. But since we're in a tunnel, we come out of the tunnel, we sew the tunnel up, and it's really very similar to just a laparoscopic incision in the belly. Only we don't do any cuts. So it's a convenient and very effective way to palliate gastroparesis. Doesn't fix anything. We're just getting rid of a tight sphincter or dysfunctional sphincter that's making a poor emptying stomach even worse. So yeah, okay, now it's at least moving. Okay, yeah, this is kind of interesting to see because it's certainly not the endoscopy that any of us were trained in. This has only been out for 10 years. So a lot of the things I do today, I've learned after training. They just weren't invented yet. So that's really exciting. And this can really help people, a lot like the celiac block, which I'll occasionally use for gastroparesis. And I don't want to forget that that's part of the workup for mouths. And doing a block can be very, very helpful for that pain. Let's see where's optimized for video clip.
Could you describe one more time what we're seeing and how that's?
Yes. Oh, we got sound. Wow. Okay. So probably not anything. So can you hear me?
Yes, we can hear you.
Oh,
we're
right,
just
good,
not quite
good,
sure
good.
what the video
Well
is showing us.
Yeah. Okay. So what it's showing is we're making a submucosal tunnel between the mucosa, the skin of the stomach, and the muscle layer deep to that. There's a submucosal layer that we inject a lot of gel into with this blue dye, and it basically makes this potential space expand so we can drive through it and make our way just a few centimeters. It looks very long to the pyloric sphincter, the circular muscle that controls stomach emptying. And so although we can't make the stomach contract again, we can open the exit, if you will, or prevent it from staying in the closed state, which it does in normal folks most of the time. And it seems to stay closed in us a lot. So if we can't fix the motility, at least you can open the drain. And so, and then regular movements of skeletal muscles can really help empty the stomach. So I'm going to try to get you to the cut of the sphincter. So this semicircle here is the pyloric sphincter. And this is just a tiny little cautery knife, which we use to cut the sphincter. And it's pretty simple. After this part, and we try to make sure we get a full thickness resection because we don't want anything growing back. After this part, we sew the entrance of the tunnel up so that everything's closed. And patients are, sore, but not like gastroparesis sore, interestingly. It's more like regular sore for about 4 or 5 days. And you can imagine cutting any muscle can make you a little tender, but it's very effective. And the data we have so far is maybe 3 or 4 years old, where 75% of people are still doing well. But I've met patients who are in flux and their disease is evolving and the autonomic neuropathy is evolving to get worse. And so what worked in the beginning may not work. And so we're thinking about combining the GPOM procedure with a gastric pacemaker wires and to try to hold off from gastrectomy. And so in this one, it's that background layer you're seeing where we're cutting through the muscle is actually the outside of the stomach. And you can see there'll be little fenestrations where you can see, the organs outside the stomach. So it's a very sort of fine tuned procedure where you have to kind of take your time. And by the way, this video is sped up about 20 times. So it's actually much slower. It makes it look pretty aggressive here. But it takes about 30 to 45 minutes. And again, it's done in the endoscopy suite. So great option to have. And then I'll show you, this is a suturing device we use to close. There's a little blood here. Nobody's bothered by that. But we close the tunnel and there's no more potential for leakage of air or anything else outside the stomach. So very, very effective. A lot of patients present are referred for GERD to the GI clinic. I didn't mention that. When I find out that their symptoms are really more consistent with gastroparesis and they have secondary reflux, all that fluid in the stomach does not tend to empty, which you saw in the drawing. And so it goes upward into the esophagus. And they can't get control with meds because meds won't stop the reflux. So a lot of people come in that way too. All right, let me move on here. So mimics and confounders. So we talked a little bit about this already. Hereditary pancreatitis, also rare, much more rare than hEDS, but we see it. SMA syndrome, very, very rare. I've rarely been convinced that that was actually the main problem, but certainly those of us who lose a ton of weight very fast can get that. And that can be treated not much difficulty. And then the MALS or MALS, median arcuate ligament syndrome, in the patient in the first video, we did an EUS to evaluate for that. We get to look at the celiac plexus, celiac artery, very like this. So let's see, can you all see the screen? Yeah. Okay. Yeah, so we get to look here at the celiac artery. And if this is sort of scrunched as we pivot around the celiac artery, then we know that there's potential for obstruction. Now, it's not a perfect test, but it's a good way to screen for that problem. And we can simultaneously look at the pancreas, and we can do a celiac block for pain relief, and we can do other things in the stomach. So I'm really happy to know that, because it allows me to take care of people with these strange, or at least poorly understood and poorly recognized disease states. I always hesitate. I don't think what we have is a disease. I think it's a natural human variant that must have a very significant purpose to be around so long. So this is a picture of MALS. If anybody hasn't seen this, basically the diaphragm, above which is your lungs, the diaphragm slips down, or I should say that the aorta slips up toward the heart and pulls the trunk of the celiac with it, so that you get this. Literally the ligament that supports the diaphragm compresses the celiac artery because it's not sitting in the right spot. And so when you eat and your stomach needs more blood supply, or your small bowel, it gets ischemic. Not enough blood, hurts like heck. And by changing body position, you can relieve the symptom. Whereas in gastroparesis, won't help at all. Pancreatitis, it actually does sometimes help. So it's still hard to tell, but that's in the differential. So I try to think about those things. And then I get so excited about the subject, that I don't want to forget about real gallbladder disease, because I make fun of the number of gallbladders removed for abnormal hEDS scans, but sometimes it's the right thing to do, certainly. And I would hate to get too fixated on the things that are being missed and miss out on the things that I was already trained on. So I'm hoping to add things to the practice, not give up things that I already have learned. So what about treatment options for colon dysmotility? So I call it dysmotility instead of chronic constipation or chronic idiopathic constipation, because the implications are different. I want people to think about it as a motility disorder, and not a psychiatric disorder like is implied sometimes. Also, it helps people get coverage for motegrity, which is one of my favorites. Zelnorm has a similar mechanism of action and will promote motility apart from the nervous system, which is important. But usually people end up getting told by their insurance companies they're going to have to take a guanylate cyclase inhibitor like Linzess or Trulance, and that's fine. That's interesting. I just saw somebody had a pain management do a celiac block. For 100 years, they've been doing those. It was only the last 20 that GIs have been doing them. And then in GI, we convinced ourselves that a celiac block was a placebo effect for about a decade because of some poorly done studies. But it actually works very, very well. So it's too bad there was a dark ages, at least for us. We don't look at the anesthesia literature. They kept on going. I think it's probably, there we go. I think it's probably very safe. That's not showing up for you guys. Very safe to do a block with EUS, because you can see the blood flow on Doppler and not going through the back. So, but either way, it's fine. If the colon totally fails, no motility, and same with the stomach, it's got to come out. If we can't medically treat whatever's causing nerve damage, or somehow get things to start working, you're obstructed, you can get sick, you can die. So There's times when we have to take the colon out. It's not something you miss, really. Most people are just fine. But there's a way to do it. So if your colon truly does fail, you don't want a subtotal colectomy, which is kind of a shortcut that pretty much anybody can do. Because if you leave 10 centimeters of colon and it's not working, it'll be just like a disease called Hirschsprung's, where there's 1 centimeter of colon that's not working. It'll stop. Everything will stop on a dime and you'll still be obstructed. So eventually a subtotal colectomy will fail. If they take the small bowel and make a pouch, which has a brief ostomy stage for 3 months, and then reconnect you, they can sort of make a neorectum and no more colon. No screening colonoscopy, no colon cancer, no polyps, no diverticulitis. Not all bad. It doesn't do much for us. That's certainly not saying that everybody needs that, but it's not the end of the world. In fact, it can. In fact, this operation has allowed 2 of my patients to come off years of tube feeds and TPN to eat again. So the obstruction was relieved finally. This is one I've seen several times. And radiologists are not in tune with motility disorders either, and are not for the most part. This is a very abnormal X-ray with a patient with colon dysmotility and air-filled colon. It's so distended, it's up near the spleen. It's actually up higher than the stomach. So the patient comes in saying they hurt in their left upper quadrant behind their ribs. And no one would guess that it's actually their colon that's moved up from the line of the belly button to their chest, but that's exactly what's happened. So that's called splenic flexure syndrome. Amazing to see these cases, because I'll look at the X-ray myself always now, because the radiologists don't have the history about what's been going on with you. They just see abdominal pain, and that's what they interpret. SITS marker studies are still useful. So these are transient markers that we can track over several days with X-rays to see how long it takes for things to move through your colon. It's useful in hEDS patients because we really need to know if there's a problem with the exit. So if all these markers on day 5 or all 22 of them or 24 of them are sitting right above the rectum, then your problem is not constipation necessarily. It definitely includes pelvic floor dysfunction. And so you don't want to have colectomy only to find out that the exit doesn't work. That's a disaster. So we need to be tested first for that. And unlike the smart pill, which just tells you raw transit, you actually get a visualization here. So that's useful. Iliac vein compression syndrome, or May-Turner. I think I saw a question recently about that. I do think it's related. There's no data that I'm aware of that would suggest that. But I think because of our connective tissue anomalies, we're more compressible, more distensible. So a situation like this, where normally an artery and vein sit so close together, is more likely to be problematic. And here it's the right common iliac artery pinches off the left common iliac vein going into the IVC, which is the major venous return in your body. So it's problematic to say the least, but yeah, I do think there's probably a relationship. So that can be thought of when we examine people in GI clinic. I don't think that's too far outside of the realm of expectations. Man, this isn't showing up either. It's on my screen perfectly. So I'm gonna skip that part. I think I'm just gonna make one point here about genetics, because I gotta give credit to the Norris lab. It really is part of my excitement. The reason that we have been sort of denied for so long is we didn't have proof. And if you look back in medical history, not too long ago, everybody thought people with H. pylori related ulcers were crazy, and they were very comfortable with that. And the people who discovered H. pylori were almost drummed out of business and out of their, the American Medical Association for the heresy to say that a bacteria caused ulcers. Well, a few years went by and that was standard of care. The same thing happened when celiac disease was found to be so important. And we just didn't expect that some sort of autoimmune disease would lead to malabsorption and diarrhea. We thought those people were crazy. And so that went away. And we're gradually losing crazy people, which makes us very uncomfortable. The next thing was eosinophilic esophagitis. We called that globus hystericus. And that was the first clue that, hey, the immune system plays a major role in motility of the GI tract. And yet we think it's just the esophagus, I guess. The final slides, which I'm going to fast forward to after I talk about this, talk about the mast cells and the drugs coming. But the reason I was so excited about the Norris Lab's work is if we have a gene test, then we can start teaching medical students and residents about the proven prevalence of the disorder. Maybe get some insight into the variations of us, why some are so severe and some are not. Certainly the immune system plays a big role in that. And I hope that it's even bigger than that. I hope that it changes the way we think about, I know it's in Charleston, South Carolina. I think that this has changed the way we think about disease, because there was one time, and not too long ago, when we broke everything up into systems to understand disease. And now we're seeing that they're all the same. It's arbitrary to say the nervous system is separate from psychiatry, from rheumatology. Everything is intertwined, and it is a very human thing to split it up as if they're unrelated. So if we just start out by believing our patients and believing that their symptoms have an explanation, even if we don't understand it, I think we'll much faster get an understanding of how this all fits together. So right now, you probably saw in the graph, the diagram that I send everybody who meets criteria to the registry at the Norris Lab, because I really want those numbers to grow and us to learn. So anyway, I thought it was fascinating that among some of the genes, it's not about collagen, it's about genes controlling function. It may be about the endocrine system and how that works on collagen. It's that's a lot of things can perturb our both the immune system and the nervous system. So let me go forward here. I think we're about done. Yep, just one second. I'm going to skip through. Yeah, so I guess the point was that this is much more complex than Ehrlich and Danlos said. And, you know, I wonder why Ehrlich and Danlos, when they studied these people for 30 years, failed to ever mention the anxiety piece, for example. I think that for a long time, we've thought that that some people are just, their symptoms were not real because they had anxiety or depression or even psychosis. And that's not something we can assume. So this is my own childhood, just to finish up. Migraines just crushing as a young boy, and I'd be out of school for 2 days vomiting. And I now think that the vomiting is gastroparesis related to a mast cell flare, which also triggers my migraines. And I've seen that in my patients, that when they start having more severe reactions to environmental antigens, everything gets worse. The migraines, the motility, things shut down, and they can come back to a degree. So I want to say, yeah, I was visited the Norris Lab and was extremely excited about that, because they're very open. It's full of us. I think Dr. Norris only takes hEDS people on his team, so everybody's kind of united in what they do. As far as the anxiety goes, I remember the claustrophobia being the worst thing for me as a teenager. I couldn't sit in the back of a car. I had to stop my parents on the side of the road and jump out. It was just completely irrational fear. And it came out of the blue. And I think I see that in a lot of my patients, that or their parents will tell me that, yeah, they really got very, very anxious when this flared up. So I know it's related, and it really shouldn't be a question about whether things are related to the overall syndrome. It's how, what we want to know. I think that is about it. I had an early brush with an EDS patient and lost my opportunity to recognize it early. this is the study data from that new drug that I was mentioning. And I shouldn't say the name of it, but trials are going to start very soon. And they were looking at it for eosinophilic gastritis and eosinophilic esophagitis. But it turns out that mast cells and EOE are one and the same. It appears in these slides. So in every sense, mast cell activation was associated with these markers, one of which we can target the MRG-PRX2 ligand. So that is going to be the drug target in the next few years. And I suspect that what they're doing at the Norris lab will potentially, I don't want to speak for Dr. Norris, lead to a therapy. And that's my own theory. I think when you find a genetic defect and the product is not functional or malfunctional, then you can give somebody normal product. And maybe offline, I'll tell you, some of you, what substantiates that opinion of mine. But having an unusual disease and having 4 children, one is a 13-year-old girl, also causes me to be very invested in this. So since there's no answers right now, I've tried some things that probably aren't ready for prime time. And so I do think there's going to be a treatment and for all of the neuropathic conditions, which is very exciting. But I'm more excited than anything about getting the word out there, seeing these seas of hEDS patients with the same symptoms be recognized and on the board exams and on the rounds. And it just should be a gimme diagnosis. And we've just been missing it for too long. So I know I've talked a lot. I'm obviously very excited. I'm happy to look through some of these questions. I didn't mention that it's very common for you to have thyroid disease, PCOS. There's things that I'm noticing that certainly aren't every patient, but we all manifest things a little different. HLA-B27 antigen, I'm positive too. Had iritis one time in my life. 6% of the country is positive. Don't know if that has anything to do with this, but it certainly might. Probably the strongest suspicion I have is that the 30% of IBS patients are the 30% that are us. So, I see a MCAS mouse ulcer question, absolutely. But MCAS can cause anything from pure neuropathic dysfunction like migraines to blacking out spells to worsening POTS and syncope to classic hives and things like that. Many people also have immune deficiency, gamma globin, hypogammaglobulinemia. So it's there's so much to learn, and again, I learn most from my patients. So I probably ought to start talking now and take questions. But I'll start looking through these. John, I really appreciate the opportunity to talk, and can't wait to hear your next episode.
Great, Dr. Penn. Boy, there's a lot of area that you covered that we haven't heard about, and we're really excited about some of these ideas, and also Norris Labs. And we promoted some things on our website, EDS Awareness. There's a couple articles about Norris Labs, and they have come up with some information about hypermobile EDS, how to diagnose it, and it's more with rather than genes, it might be enzymes, or it might be another type of, material.
That's good. Yeah, I never know how much to share.
Yeah, I know. I'm not sharing very much, but I'm just saying we have an opportunity to do a webinar with Chip in the near future. He's now formalizing his articles and his formal documentation about this. And he wants to wait until that's all done before he does much more promotion. But sure. Fantastic. If you could answer a few questions, you have 74 questions. You're not going to get through all those.
Okay.
But if you could start a few, I'd appreciate it. Thank you.
Okay, let's see. Now, this is not self-promotion, but if you're in Facebook groups, there's a Dr. Penn Gastroenterology. If anybody wants to ask questions in the future, happy to get involved. I may ask you questions. So, but that's the site where I sort of communicate online. And the severe GERD, yeah, pulmonary fibrosis certainly is a function of severe GERD, and gastroparesis makes GERD terrible. So that's not surprising. Some aortic question, man, there's a lot. Let's see. Can my stomach pressure cause abdominal aorta to be compressed? Well, possible, yeah. In the same way that the iliac artery compression syndrome occurs. I don't know the answer to that, but if it's going to happen, it would be more likely in us, because I think the walls of our arteries and bowels are flimsy, like the rest of us. Again, don't get down on yourself. We have our own crosses to bear, but we tend to be extremely intelligent, beautiful skin, and age well for the most part, except for the joints, and resilient. So we get used to having negative stimuli, and we figure out how to stay positive. So I believe those things are very true. So there's got to be some benefits to this for it to be so common. I don't know what those are yet, but it wouldn't be so common if there wasn't some reason. Let's see, if anybody wanted about the Norris Labs, it's just norrislabs.com. Russell Norris and Courtney Gensmer is excellent. She is a PhD candidate who's very, very active on social media, as well as in research circles, big publications. She's been integral in the discovery, and I can't say enough good about her and their lab. Let's see here. I got a lot of thank yous, and I thank you for saying that, because this is something that interests me so much that I really don't. It doesn't feel like work. It feels exciting. Let's see. So contact again, Dr. Penn Gastroenterology on Facebook is probably the best way. Let's see, is there a specialist in your area to manage EDS patients? No, I'm sorry to say no. So we do have some good EP, electrophysiology for POTS. Immunology, I think if you had to choose one person who really knew what they were doing, it would be an immunologist, and maybe in the future, a rheumatologist. I actually think gastroenterologists are going to play less of a role, which I would be disappointed about. But this is a problem with the immune system, and will probably be addressed on an endocrine basis. So, in my experience, these patients that I'm talking about and I've met in the last 6 months, they don't really want to come back so much. We do some follow-up and we talk and we text, but once you have an understanding of what your symptoms are from, and you kind of know with the tools, you're empowered to choose when you take the next step. So compared to IBS, which neither the doctor nor the patient knows what's going on, that was just a mess. MCAS is evil. Yeah, it's absolutely evil. Like I said, that was a patient who's on death's door, who in March was doing fine, working, and she's a medical professional. And I called Emory, and we decided that the most important thing to her fate was having somebody who wanted to help her and didn't necessarily know what to do, because nobody really knows what to do at this point. And so that was a big compliment. And she just wanted somebody in her corner, because often hospitalized patients really need an advocate. Folks just don't understand yet. Let's see what else. Yeah, the Norris survey. So all you have to do to get into the Norris registry, from my understanding, is have a diagnosis by a physician based on the Villafranche criteria checklist, and that's on the EDS Society's website. So a physician will ask you those questions, put them in your chart, and you're done. Sometimes I'll meet nurses in the hospital and just fill it out for them and put it in their chart, as long as it's positive. Okay, let's see here. Resource prevalence heads didn't seem to think.
While you're looking at those, I've got a couple questions about the recording. Yes, this will be and is being recorded. It'll be posted on our website, and also the slides will be there as well in a couple days. So you'll get an email that will give you the link to the website, but it's basically edsawareness.com. So
great. One more important thing to address. So although I said that this we may not have a multi-specialty group to take care of EDS. Not many places do. There are a few, and there's some problems with the models. At this point in the game, with so few people buying in the medical profession, it's about getting one strong advocate who will bring on another aware physician who will be an advocate and sort of to grow that. So I don't think, I think there is a ton of information on these webinars, these recordings online that patients can learn without, necessarily traveling a distance. There's a lot of reading, like the book John mentioned. There's the details get very, very in depth if you want that. But, I'm no, immunochemist, but I'm looking at that sort of data to try to figure out what's going to work. And so with that level of excitement, as long as we get enough of us on board to sort of to get excited, patients will get what they need. And I don't think you have to travel necessarily. There's some notable exceptions to that, some gurus who would certainly be worth getting their input. But in my experience, patients are very, very well versed and know things that I don't know when I meet them. The only other thing I wanted to say is somebody asked about telemedicine. Yeah, I'm thinking about sort of setting up a telemedicine site, because most of what I do, since I don't put people through the algorithm that we started with, once we recognize the diagnosis, it's mainly figuring out treatment recommendations, whether the appropriate screening's been done, and which specialists they may need to see who they didn't previously just need to see. And then I tell them what also, sort of off the cuff, what would I do if that was my daughter or myself? I think that's fair with a disease that's poorly recognized and no, a particular specific therapy. It's fair to tell people what I think I might do. So yes, to telemedicine. I'm trying to set up a website where I can do that sort of on the side. Let's see. Oh, physical therapy. I did not mention how important that is. I think you all probably know that. Psychology is very important. It takes cognitive behavioral therapy often to break the claustrophobia and the social anxiety. Certainly medicines are helpful, but there's no shame in either of those. In fact, it's very, very important. I see somebody agree with the claustrophobia. That's such an odd fear. Yeah, Miss America is one of us, and speaks openly about that. Several stars, and I think I should have shown a picture of my mother. She's the quintessential EDS patient. It takes an hour and a half to eat dinner, and that was her adaptation. But I think when I see particularly women with this disorder, it must remind me in some way of her. Sunil Patel, the neurosurgeon in Charleston, has the same feeling. He can spot people and confirm on the spot that they have this. And just striking that to us that we've been in the dark or maybe had our heads in the sand. So thank you again for letting me speak. If anybody wants to contact me, please feel free to send a message, and Dr. Penn, gastroenterology is probably the best way to do that.
Yeah, thank you again, Dr. Penn. And we'll put that contact information on the website, along with the video and the slides and information about your clinic, so that people can have an opportunity to contact you to learn more about your programs. We also have 2 articles out there about the Norse Lab and we're hoping to put more information as it becomes available. So any final comments or any final message you'd like to leave us with as we wrap up this evening?
Just keep your chins up and stay hopeful. I think the future is finally bright, and things are going to get better. So, and stay united. It's really nice to see how people bond together. That's probably the best thing I've seen about the internet. So.
Yeah, absolutely. In fact, we have a very robust support group in Atlanta, Georgia, and that's Melissa heads that up, and she had some very positive things to say about you. So you made an impact on her support group. So we have also other support groups on our site. So if people are interested in finding other people that they want to talk to, please let us know. So we're going to wrap it up this evening, and thank you very much. And we appreciate all your information. This has been phenomenal. We really enjoyed it. You have a good evening.
You too.
Thank you for participating, all the attendees, and we'll have a good day, have a good evening, have a good weekend. Have a good holiday that's coming up too. Good night.
Good night.